Dear colleague, welcome to this course regarding intraoperative evaluations. The course is based on the chapters above. The first chapter deals with the different methods used for intraoperative evaluation, intraoperative macrostimulation, impedance recording, local field potentials, and microelectrode recording, while the two last are personal reflections on the controversies regarding microelectrode recording and the sleep surgery. After you have decided where to put your electrode, it is necessary to confirm that the electrode is correctly placed in your intended target and possibly to optimize the location. This is done using one or more of the techniques for intraoperative evaluation, all with different advantages and disadvantages. The major difference between different groups performing DBS is how we perform this intraoperative evaluation. This is especially true since which technique we are using will also affect the targeting and whether the procedure is performed with the patient awake or asleep. The minimum is to visually verify the anatomical location of the electrode by CT or MRI. Other methods can be used to gain further information. How to identify the electrode is discussed in the course Visual Identification of the Electrode and will not be repeated here. Regarding macrostimulation, the advantage is that you can use the DBS electrode and that you will get a verification of the effect of stimulation at the actual location of the electrode itself. A disadvantage is that the stimulation response is sometimes not so simple to interpret, and I suspect that sometimes perfectly well placed electrodes are relocated for the wrong reasons. Another disadvantage is that it requires the patient to be awake during surgery. Regarding impedance recording, this is very fast and do not take more than a few extra seconds if you are anyhow using the radio frequency electrode to create a channel for the DBS electrode. The provided information is limited. Most importantly, it will tell you if your electrode has incorrectly ended up in the ventricles or in the internal capsule. Local field potentials is an experimental method of which I personally have very limited knowledge. So you will get further information from Dr. Aviva Bosch and Anand Tekrival. The same is true regarding microelectrode recording, where Stéphane Chabardes and his team from Grenoble will provide more information for you. So, which techniques should we use? Well, DBS is a handicraft. The tools we are using are important for our ability to create a result of high quality. However, our ability to realize the potential of the tool is dependent on who is using it. Many of us are experienced in our preferred technique. Changing this will transform us from experts to novices and might lead to deteriorating results until we master the new technique. Which technique would be best in the hands of an expert with equal expertise concerning all techniques for intraoperative evaluations is unknown. To use all techniques simultaneously would maximize the available information. However, this would be time-consuming and likely to cause information overload and confusion. More is not always better. Whatever techniques you are using, the most important thing is that you master them well. The techniques for intraoperative evaluation are best studied by reading the chapters presented above. I will here continue with some personal reflections on the controversies regarding microelectrode recording and sleep surgery. So, why I don't use microelectrode recording? This is not a scientific review of the literature trying to imply that no one should use microelectrode recording. These are just some personal reflections. Microelectrode recording has, as do other methods for intraoperative evaluation, a scientific value. However, it is most often not performed for scientific purposes, but as a part of a clinical treatment. The debate regarding microelectrode recording has been long and often heated. The champion of one method will sometimes advocate this as the only truth. In reality, different techniques have different advantages and disadvantages that will be differently suited to different persons, teams, and situations. Microelectrode recording is also heterogeneous. I will discuss it here as a uniform technique, but variants are abundant. It is more suited for some targets than for others. It seems to be most appreciated regarding the STN, but also in the VIM and GPI. In the caudal zona incerta, it appears to be of low value, while in the anterior nucleus of the thalamus it is frequently used, although not with multiple tracks due to the local anatomy. It is sometimes used in psychiatric targets. Some groups use it with a traditional array of 5 electrodes where each trajectory is carefully analyzed by a neurophysiologist. In other groups, the neurosurgeon introduces and evaluates himself one single electrode. Some groups use microelectrode recording based on atlas targeting in order to identify the target. Other groups use microelectrode recording based on visual anatomical targeting in order to verify the target. In truth, the most important reason why I don't use microelectrode recording is simply that it was not used by my mentor nor by his mentor. Thus, here are the reasons why I today do not consider to start using microelectrode recording. Today we have other choices than 55 years ago when microelectrode recording was introduced. It is an old technique introduced in 1962 when we could not see the targets. Further, during that era, irreversible lesions were the only options. Today, with DBS and MRI-based visual anatomical targeting, we can both identify the actual targets and verify that the electrode ends up in the intended target with CT and MRI. We might want to go with the flow. It is not always wise to move with the masses. However, one should neither despise the wisdom of the collective. Perhaps it was on average better for the average user to rely on microelectrode recording when the overwhelming majority was doing so. Today we see a trend away from this. The number of centers relying on visual anatomical targeting is increasing. More and more centers are reducing the number of tracks or abolishing microelectrode recording altogether. And centers previously using this technique are now happy to perform ultrasound lesions without microelectrode recording and without any probe at all in the brain. It is terribly expensive. According to this study, microelectrode recording more than doubles the cost of STN-DBS in Parkinson's disease and more than triples the cost for a unilateral or staged bilateral procedure. It is complicated, and it requires, or at least it is common, to have a neurophysiologist in the OR. It is not optimal in general anesthesia. According to some, it is not possible to perform in general anesthesia. According to others, it can be done, but with less quality. It is not a replacement for visual targeting. Microelectrode recording is used secondary to either atlas-based targeting or MRI-based visual anatomical targeting. However, the atlas is often not in accordance with the individual patient, and the differences can be so large that a whole microelectrode array with 5 electrodes will miss the target structure, as seen in the example to the right regarding the GPI. And if you can see the target structures, it is not acceptable to rely on atlas coordinates. Microelectrode recording has a low resolution. The distance between the electrodes is 2 mm, providing a low resolution in the target area. Targeting today with visual MRI-based targeting can be made in great detail. If one uses atlas coordinates with microelectrode recording to find the target, these details are lost and we end up with a poor 2 mm resolution. It can of course be combined with visual targeting in order to confirm and evaluate the target. To have several electrodes will provide more information than if you had only one, but the point is that with such a low resolution, you still need excellent visual anatomical targeting. The 5 electrodes might be enough to save you if you have a deviation of the electrode, but not if your targeting was suboptimal. It might be difficult to find an optimal trajectory. The diameter of the holes in the bend gun is 1.9 millimeters, and the diameter of the whole array is thus 6 millimeters or 5.65 millimeters if looking at the guide tubes. When introducing electrodes, we want a safe trajectory that will not enter sulci, ventricles or vessels in order to avoid brain shift, misplaced electrodes and hemorrhages. Especially when the brain is atrophied, it is often difficult to find a safe trajectory for one single electrode with a diameter of 1.3 millimeter. Imagine how difficult this can be when the diameter of the microelectrode array is 6 millimeters. You need a large opening of the dura during a long time, and this leads to increased CSF leakage with risk for brain shift and electrode deviation. Using the array with 5 microelectrodes and assuming you open the dura, you need a durotomy of at least about 8 millimeters, and the testing can take hours. This can be compared to the technique we are using, where you have a small durotomy that is not open for more than 2 minutes. We further have the problem with tissue damage. The tip of the microelectrode is very narrow, but this is not the case regarding the guide tubes which are introduced close to the target. We know that by simply introducing one electrode, we will sometimes get irreversible effects from the microlesion created. And the tissue damage must be more severe when introducing an array of 5 guide tubes through the caudate nucleus and other structures. There is an increased risk of intracerebral hemorrhages. If you look at the literature, then microelectrode recording seems to be associated with up to 5-fold increased risk for hemorrhages compared to not using microelectrode recording. Further, it seems as if most deaths following DBS are secondary to hemorrhages in patients where microelectrode recording was used, and the risk seems to be around 2%. It has been stated that this risk can be reduced by diminishing the number of microelectrodes, careful planning of trajectory, etc. And some groups using microelectrode recording have also reported a low incidence of hemorrhages. The covering of a large area with multiple tracks seems to be a more appreciated feature of microelectrode recording than the actual evaluation of characteristic neuronal activity, at least among neurosurgeons. However, even if these multiple tracks can be convenient, they might have negative effects as discussed above. Further, the value of multiple tracks is not completely clear. My guess is that today an experienced group will choose the central microelectrode trajectory for implantation of the DBS electrode in almost 80% of the cases. Thus, in about 20%, another trajectory than the central will be chosen, but exactly why or how important this is is unknown. We don't know what result the central trajectory would have provided regarding chronic DBS compared to the chosen non-central. We don't know if the chosen non-central trajectories are located besides the intended target or actually in the intended target. I suspect that the chosen trajectory will often be close to the point originally intended for the central trajectory, and perhaps brain shift and electrode deviation can be reduced by abandoning microelectrode recording. Perhaps it's possible to optimize the targeting further. I suspect that groups using only visual targeting and one single trajectory might spend more time on the finer details of the targeting. Today we have directional electrodes that might reduce the potential advantages of multitrack microelectrode recording. Directional electrodes are not an excuse for poor targeting, but considering the poor resolution of multitrack microelectrode recording, they might serve a similar purpose. Instead of moving the DBS electrode 2 mm, you can move the field of stimulation to some extent. There is no guarantee that the DBS electrode will end up where the microelectrode recording was done. This might be a problem in patients with brain shift. And microelectrode recording does not guarantee a correct electrode placement. It can be a help, but it's not a guarantee. There are numerous examples in the literature of misplaced electrodes following microelectrode recording based surgery, both because the electrode has probably deviated from the site of the recording and because of incorrect interpretation of the recordings. In this analysis of 28,000 DBS procedures in the USA, up to 34% were actually electrode revisions, most commonly because improper targeting or lack of effect, and this despite microelectrode recording was used in 87% of the cases. Finally, microelectrode recording does not lead to better results. There are no randomized studies comparing microelectrode recording based DBS with non-microelectrode recording DBS based on visual anatomical targeting. However, the efficacy seems to be about the same if you look at the published literature. To design a study comparing the techniques would be very difficult, since this should only include centers equally experienced with both techniques. Further, a very large material would be needed, since any differences in efficacy are likely to be rather small. In conclusion, I don't use microelectrode recording, and I am happy with this. If you find microelectrode recording to be valuable, then you should use it. So, the question is, awake or asleep DBS? Unfortunately, the answer to this question is not that simple. Most colleagues will agree that all things equal, asleep DBS is to be preferred. Unfortunately, not all things are equal. DBS is performed with the patient awake in order to allow intraoperative macrostimulation and or microelectrode recording for identification or verification of the target. Asleep DBS is common today, but not for all targets. Since intraoperative evaluation with stimulation or recording is of varying importance in different targets, the GPI can be easily visualized and macrostimulation provides limited information. Thus, GPI DBS is today mostly done in general anesthesia. The same is true regarding the targets for psychiatric disorders as well as the anterior nucleus of the thalamus. Thus, the question today mainly concerns the subthalamic nucleus and thalamic subthalamic DBS for tremor. Regarding the STN, stimulation or recordings can provide valuable information. However, with visual anatomical targeting and image-verified DBS, this information is no longer fundamental. And today, more and more centers are performing STN DBS in general anesthesia. There are no randomized studies comparing awake and asleep surgery, but the results seem to be comparable according to the literature. Regarding subthalamic DBS for essential tremor, there has been more reluctance to perform a sleep DBS. Only few do this in general anesthesia, and the only study published demonstrated comparable results between awake and asleep VIM DBS. I would myself be reluctant to do VIM DBS in general anesthesia, since this atlas target cannot be visualized. However, since 13 years I have replaced the VIM with the called zona incerta, which can be visualized, and since 5 years I do all procedures in general anesthesia. When we compare the results, there are no significant difference concerning the effect between asleep and awake surgery. But a word of caution. I performed STN DBS in awake patients for 10 years and in the VIM zona incerta for 15 years before changing to general anesthesia. I started with general anesthesia when I had verified that as long as my electrodes were well placed within the target, test stimulation would provide little information of further value. Further, when my accuracy was so good that I always ended up close to the intended target point. Asleep STN DBS and zona incerta DBS is acceptable only when you know how to properly identify the target and when you verify that the electrode has ended up in the target. So, why might a sleep DBS be desirable? Well, a sleep surgery is much more convenient for the patient and for the surgeon. We get a better quality of the MRI, movement artifacts are abolished and longer MRI sequences can be used, resulting in better quality of MRI and hence possibly better targeting. A completely horizontal position is uncomfortable for the patient in awake surgery, but does not constitute a problem in general anesthesia. And as discussed in improving accuracy, this has several advantages. Inserting the electrode with the patient in the same position as when performing the MRI might increase accuracy. Because targeting the lying brain but implanting the sitting brain might cause the electrode to end up somewhat too posterior and too high. Further, in a horizontal position, the CSF leakage is reduced compared to sitting because the brain is pressed towards the burr-hole site, thus effectively sealing it. And in general anesthesia, a slight positive pressure will contribute to this effect. It is also much faster. Several parts of the procedure are faster in general anesthesia. Most importantly, the implantation of extension cable and IPG can be done directly without removing the frame, as we see in the video to the right, and this saves a lot of time. Further, we do not have to spend time on macrostimulation or microelectrode recording. In general anesthesia, a unilateral procedure, including implantation of the IPG and connection cable, will typically take me exactly 1 hour. We then have the public conception of DBS. DBS has achieved a lot of attention in the media, and this is partly due to the high-tech profile of the procedure and the results presented. However, the procedure is often perceived as a last option when everything else has failed. A device reminiscent of the Middle Ages is fastened with screws to the head. The surgeon will then drill through the skull and penetrate the brain of the poor awake patient. But the patient do not care about what devices you are using during surgery if he is asleep. By performing all procedures asleep, keeping the hair, and when indicated hiding the IPG, we can change the patient's conception of the procedure. The procedure is today by many of my patients perceived as a quite small procedure, although technically advanced. Further, some patients who previously declined surgery are now accepting. It is also possible that it's more cost-effective to do the procedure in general anesthesia. So, in conclusion, DBS can be done asleep with similar results as awake. This reduces your possibilities to use intraoperative evaluation to confirm the target. Asleep DBS is heavily dependent on your ability to properly identify the target and confirm that you have reached it. Asleep DBS has advantages worth striving for, but should only be performed when the efficacy of the treatment can be maintained. Thus, whether or not you should do asleep DBS is mostly a question of how much you consider macrostimulation or recording worth to improve your personal results. And with this I end this presentation and thank you for your attention.